Good afternoon, everyone. About dental implantology, as we know that we are practicing in a good way with the profound concepts, basically leading to rehabilitation of the missing tooth. Example, if we take this jaw into consideration, the jaw surgery is the basic of it, wherein we need to understand that this is the tooth and here is the missing edentulous area, probably lost due to periodontitis or dental caries extracted by a dentist or self-immolation by the tooth. Now what I want to show you that if this is the place we are not having the tooth, what are the steps needed to rehabilitate it? Now the type of rehabilitation is not only depending on the cost but solely depends on the biomechanics. The biomechanics is very important while we go over tooth rehabilitation, because if we place a tooth there, artificial tooth, its role is not only to chew but to be stable and of course tolerate the stress induced due to the mastication and the bone itself. Okay. Now coming down to it, suppose I feel like here is a case which comes to us. So let me just explain you that this is one section of the jaw and here is the hollow cavity. It's the first bicuspid and probably the second bicuspid is missing, and we are planning to rehabilitate this area with the help of a tooth which is implant supported, a prosthesis which is implant supported. So what we do exactly? Now what is an implant exactly? Implant is a fixture which is placed in the bone, inside the bone, with a proper bone implant contact and waiting for a period with a thorough osseointegration without affecting the soft tissue envelope. This is what we are expecting out of an implant, enabling it to load it with an adequate process which helps in restoring the oral functions. So taking into consideration the placement of implants, I will show you that this is the ridge which is lacking tooth. This is the tooth. This is the ridge which we are lacking the tooth. What we do exactly, we try to place an implant, a fixture, a root analog inside the jawbone. When you place it inside the jawbone, you need to assess, is there a adequate width, length, volume, architecture of the jawbone available to complement to the implant size, so that we can maintain the or achieve the bone implant contact. If the answer is yes, we take into consideration and decide the implant dimension and fix it with proper drilling sequence and try to achieve the primary stability, as a result of which it can be weighted or immediately loaded for the process to come into action. This is what about the implantology in the bone. And what I want to tell you, that it's not only the tooth or the implant or the bone that is coming into picture, it's also the risk areas coming into picture. Those are the anatomical limitation. For that limitation to study, the knowledge of anatomy is very important for us. And as we clearly appreciate it for the surgeons and dental professionals, it is completely a maxillary area. We have to consider an area, a hollow area, which is very popular in maintaining the resonance of the face and the voice, make the skull lighter, make the air warmer, prevent for us to breathe in and maintain the quality of the respiratory air passage, is nothing but the major sinus, that is the maxillary sinus. Okay, so this is a window made just to make the beginners understand, also for the ardent practitioner to appreciate the maxillary sinus. Now, whenever I am going to understand the maxillary sinus, I need to understand that there is a hollow area. So let me demonstrate the hollowness of the maxillary sinus. This is the hollow maxillary sinus. you can appreciate. It is completely this area. Okay, that's again very true to this case. Now, this maxillary sinus needs to be healthy so that we can manipulate its volume. Yes. When it comes down to its volume, we need to understand the presence of tooth makes the maxillary sinus very much optimum for its function, as discussed earlier. Now, a case comes when we lose our tooth. There occurs expansion of the sinus filled with air, known as pneumatation of the sinus area. The duration of edentulous is proportional to the pneumatation of the sinus. We need to take into consideration that pneumatation of sinus needs to be understood, if not arrested, at the point of or the cross section where we are planning to rehabilitate the patient with it. We are okay with the sinus. We are having a thickness of the alveolar bone. This is marked with this line. We place the implant. We try to achieve the maximum bone implant contact. If not, with the alveolar bone, we go for a sinus lift and graft or compact a bone here. So this, when we directly view it and we try to fill it, this is a direct sinus lift. We create a window, lift the sinus membrane, place the bone, suture it, create a window after that. I will close the window after that. If we are not interested to see the sinus cavity or the sinus membrane, the Snegerian membrane, and we go to indirect method of lifting the sinus, that comes to the indirect sinus lift. The guiding factor is again the thickness of the bone. The thickness of the bone is the guiding factor for the two appropriate techniques apt for the patient to do. In this way, what we do, we try to achieve the optimum fixture placement and a successful primary stability followed by secondary stability through the process of osseointegration. So if come down to the osseointegration, we find that it is not a standalone procedure. It is a biochemical procedure in which either we go for autologous graft, or autogenous graft, or a allogenic graft. The main aim is either they induce the the bone formation, okay, or they can easily form a scaffold or which the bone formation happens. But what happens if there is lack of vascularity? That is a case of atrophic jaw. That is a point of discussion now. In case of atrophic jaw, our basic aim should be to rehabilitate the patient to withstand the biomechanic forces, the integral stress strain, to satisfy the biomechanics again with the help of generated for the aspiration of chewing food, so that we can easily achieve the maximum optimum oral health through this processes. Fine. Now imagine I don't have a bone here. The alveolus is gone. Neither it can be augmented. Yes, for augmentation, what we need a blood supply. In case of atrophicity of the structure, the first is the loss of vascularity, which result in rejection of the graft material, be it be particulate, be it be a block, be it be of any type. What can we do at that moment? Yes, we need to preserve and find what to preserve. From where to take the anchorage point, wherein our fixture is going to stay. The concept is now again coming down, which all of you are hinting about, is about where to take the anchorage for the stable processes. That is again a question for us which needs to be addressed, and I guess that during this my small introduction one is able to understand what I am going to point it out. The answer is very clear. We need to take extra alveolar anchorage. What does that mean? You might not take this one, the alveolus, the residual ridge for the anchorage. We might take an area adjacent to the alveolus in line with the forces which will minimize the cantilever and respect the biomechanics and the stress strain modules. What can be the area? We all know that these are hollow structures. So what is the near about strong, sturdy structure which is not amenable to resorption and basically a stable landmark? So it's nothing but the zygomatic process related to the zygoma here. Here in the bone is quite stable, quite sturdy, quite ardent for placement of the implant. That is what I want to tell here, that once we try to reach this area, so where shall we start for it? The answer is the coronal placement of implants reaching the zygoma. Now comes how to reach here and from where to start. The starting point is somewhere in the near the alveolus, which will guide the processes to frame here in a beautiful manner. So, how to reach that point? That comes to our mind. Now the thought process starts at this moment, that if we involve the alveolus, if present, it depends on the type of ridge and the width and thickness of the ridge. We all know now it is lacking the dimension for an endoosseous implant. We need to go for an extra alveolar anchorage. So what we do here, we primarily, if you can focus here, we primarily target this area. Let me explain you. This zygomatic arch has been cut from here. Just to explain this model is not fit for the zygomatic arch understanding, but we have tried to explain it, and it will help us if you imagine a bit so that the understanding becomes very clear out of it. Now, if you take this into consideration, the alveolus, and considering this to be thick one, and reaching to this point. Now, first and foremost important point which I have discussed earlier is the bone implant contact. While planning to place the implant, it should be circumferentially surrounded by the bone. Now, we know there is a sinus here. The sinus is either a limiting structure earlier or a medium through which our implant should pass to achieve this bone structure, which is zygomatic. Yes. So, where to start with the implants, how to reach to it. There are two philosophies. In short, I am trying to explain you. Those are patient specific and really understood by the width of the bone and to achieve this zygomatic process. So, if this alveolus is taken into consideration, if it is having a good thickness, we can plan to drill from this side and reach the zygoma here. This can be the look, assuming that this part is out. This can be simulated or thought of with the help of a tunnel, where we are digging through it and reaching here. Now imagine a canal. What happens in a canal? We know that the canal flow and you have got a water base there and the roof is not there. Imagine if that situation can be understood if we go for a thinner alveolar ridge, a more atrophied ridge, and we take into consideration that we used an extra alveolar anchorage or drilling out of the sinus and reaching the zygomatic process in this way. Okay? In that way we know that we are not sufficiently covered by the bone here. What we expect, that our implant should go inside the zygoma and it should be somewhere visible from here. Okay? So here the osteotomy site is guided by the perforation, what we are planning to do inside the zygoma for a proper visibility to achieve a proper osseointegration. Yes, the titanium is there and it will achieve the osseointegration. Now this can be the actual look where the zygoma implants are here. we can use this as a type of processes and understand this. Okay, and we can take the leverage from this side, the angular side, or the residual side. What is guiding us? The residual bone in the alveolus, the abstinence from the soft tissue contact. The soft tissue should not be irritated, and if the soft tissue is irritated, it might lead to restriction of the hemidesmosomes which is formed between the implant surface and the soft tissue. So there are many guidelines. One of the most important guidelines for the dentist, for a general practitioner, or for anyone practicing implantology is not to probe in the area around the implant. A small tip, which is I am talking it beyond the prosthetic phase also, in the maintenance care of the zygomatic implants. So the basic fundamental lies in one point: maintain the BIC, that is bone implant contact, respect the soft tissue, respect the periodontium which is there, and achieve the stability for the implant process. Thank you, and I will be speaking more on that in my upcoming series. Thank you so much.